in today's international webinar under the title of Updates in the Management of Carcinoma Colon, Recent Debates and Developments. I am Dr. Ishtiaq Alam, Assistant Professor of Surgery in Salimullah Medical College Hospital and Medical College and Mitford Hospital in Dhaka. To begin the proceedings, let me have the honor to first invite Professor Motiur Rahman sir as the Honorable Chairperson of this webinar. Sir. Professor Motiur Rahman sir is also the convener of Bangladesh Society of Colon and Rectal Surgeons. We are honored to have Professor Konok Khanti Barua sir as the chief guest for this webinar, a legendary neurosurgeon, academic enthusiast, and veteran for all surgical disciplines. Professor Konok Khanti sir is currently serving as the Vice Chancellor of Bangabandhu Sheikh Mujib Medical University.
Hello, Assalamu alaikum. Good evening, everybody. I am Dr. Bilqis Fatema, Assistant Professor of Colorectal Surgery from Dhaka Medical College Hospital. And it is a matter of great honor and privilege for me to get the opportunity to welcome the distinguished speaker of today's webinar. Our first speaker is Dr. Sandip Nayak, a well-renowned name in the field of laparoscopic and robotic surgical oncology from India. Dr. Nayak is currently working as the Director of Surgical Oncology in MACS Clinic and Fortis Hospital, Bangalore. Sir, it is a great matter of honor for us to welcome you in this webinar. Our second speaker for the session, Dr. Mark Ong Tae Ching, an internationally acclaimed academic, general and colorectal surgeon in Singapore. Dr. Mark is the medical director and senior consultant in the Mount Elizabeth Novena Hospital and Mount Albernia Hospital, Singapore. He is well versed in laparoscopic and robotic surgery for both cancer and benign disorder. It is our proud privilege, sir, to have you with us. Thank you all.
Assalamu alaikum. Good evening, ladies and gentlemen. I am Dr. Muhammad Ariful Alam, Assistant Professor of Colorectal Surgery in Rajshahi Medical College. And I am honored to have the opportunity to welcome the distinguished panel of experts for today's webinar. Our first panelist is Dr. Anil Hirur sir, an eminent senior oncosurgeon and head of Department of Surgical Oncology, Fortis Hospital, Mulund, Mumbai, India. He has been invited as an active faculty in numerous national and international conferences and has numerous critically acclaimed publications to his name. As the second panelist, we have our beloved Professor Dr. Shahadat Hossain sir, an academician, educator, trainer, and mentor in the field of colorectal surgery of Bangladesh. Sir is currently the Honorable Chairman of Department of Colorectal Surgery, Bangabandhu Sheikh Mujib Medical University, and also the Member Secretary of Bangladesh Society of Colon and Rectal Surgeons. Next, we have one of the prominent colorectal surgeons of Bangladesh, Professor Dr. Shahadat Hossain Sheikh sir. Professor Sheikh sir is considered the pioneer in the laparoscopic colorectal surgery in Bangladesh. We have our Professor Dr. Muhammad Abu Tahir sir, an inspirational colorectal surgeon and Professor of Colorectal Surgery from Bangabandhu Sheikh Mujib Medical University. Sir is also currently acting as the Treasurer of Bangladesh Society of Surgeons. Thank you.
Dear audience, let us move on to the presentation part. Our first speaker, Dr. Sandip Nayak sir, I would like to request you to kindly start your presentation, sir. Dr. Sandip Nayak sir.
Thank you very much. Thanks for inviting me to address this August gathering. I see that many senior surgeons are there, and I see that it's a very, very well organized in society. That is very nice to see, because whenever we give talk to at many societies, we realized the difference between a well organized setup and a setup which is not so well organized. So I really appreciate the quality of care and the way you have organized this. So I'll just start my slides. I'll first share it 1 second. Let me see if I have a camera which I can come in within the slide itself. Let me see whether I can do that. That will be better, so that you can see me as I present. If it works, I'll do that. So I think now you can see me, right?
Yes.
Yes, sir.
Yeah, we can
So
see you. We
Yes,
can
sir.
see you, sir.
Yes, sir. We can see you and hear
Very
you
cool.
also.
Very cool.
Yes.
That's great.
Nice. So here we go. So I'll be talking about right colonic cancers, how far we really need to go. Basically, we are talking about the different lymph node dissections which are required and what is the evidence as of now. So this will be the discussion which we'll be having. I have 20 minutes to do this, so I'll be discussing on this various aspects as we go on. So the learning objectives of today's presentation are the concept or itself, the anatomy which we should understand when we are doing this kind of or D3 dissection or any of those things. What is the evidence as of now, and what are the surgical steps? So this is the learning objectives of today's presentation. Now, the first thing which we need to understand is but there is a difference which we will try to understand as we go on. That we'll understand when we talk about anatomy, what it means. Now, what is actually a total complete mesocolic excision? So for this, we need to understand the anatomical aspect of what is mesocolon. When we talk about mesocolon, like, when we talk about the TME, we talk about the facial layer, the endopelvic fascia is what we're talking about. But when we talk about mesocolon, we don't have a well-defined fascia there. There are two planes which have been discussed and defined. One is the mesofacial plane, other one is the retrofacial plane. This is in reference to the Toll's fascia. So the Toll's fascia is the reference point for us. So if we go superficial to it, that is the mesofacial separation plane. Other one which we talk about is a retrofacial separation plane. So in practice, Toll's fascia, when it is behind the colon, is actually a very, it's a loose areolar tissue kind of a plane. So we are not looking at some plane which is like, the Gerota's fascia or anything like that. It is loose areolar tissue. So the idea is to get in between the mesocolon and the Gerota's fascia, which is posteriorly, or the retroperitoneal fascia, which is posterior. So that plane has to be maintained. So the idea is that you should not breach into the mesocolon. So as long as you maintain that plane, that is the right plane, and all the fibrofatty tissue and the representative lymph nodes of the colon go up with the specimen when you do that. So that is a complete mesocolic excision. Now, also here, if you see, the central vascular ligation is discussed. See, central vascular ligation, when we say, we are referring to the artery. So if you ligate the artery at its origin, that is central vascular ligation. So the two concepts are slightly different from each other. You need to understand that. And when we come to the D3 dissection, we are looking at the going an extra bit over the vein, that is superior mesenteric vein. We need to go that extra length to clear the extra lymph nodes on that. That is D3 dissection. So this is a Japanese description which I picked up from one of the journals. And if you see this, when you do a central vascular ligation, you can achieve a good D2 dissection of the lymph nodes. But you cannot achieve D3 just by doing that. You need to go medial to the vessel. Now, another thing, if you notice here, it is possible to reduce the amount of resection over the colon by confining to this lymph node drainage pattern, the central lymph node. These are called central lymph nodes. This is how it is defined, the central main lymph nodes, what we call. So if you can go to them even by reducing the extent of bowel resection, because we know that we can restrict it to even 5 centimeters to 10 centimeters. That's more than adequate for us to give a good clearance. But most of the times it may not be practically possible. You have to go extend it, but then it is possible technically to do it. So this is what is more important in survival than just doing an extending the resection on the bowel. Now, what is this D3? What are the dimensions or the extent of dissection when we talk about, or the area called D3? What are the boundaries? It is very important to understand this boundary. See, to the, it actually, the lateral boundary or to the right is the 1 centimeter of the mesocolon. So from 1 centimeter to the right of the superior mesenteric vein starts the D3 uh, on that side. So beyond this is the D2 lymph nodes. So that is, to the right of this is the D2 lymph nodes. Now, vertically, what is the extent? Inferiorly, it is 5 millimeters inferior to the origin of inferior, ileocholic artery. So if you go 5 millimeter below that, that is adequate. The medial margin is the superior mesenteric artery. If you go to the superior mesenteric artery, that is sufficient. And superiorly, you have to go 5 millimeters above the origin of the middle colic artery. So this is the boundary which you have to clear when we talk about D3 dissection. This is the D3 region. So many of us comfortably do D2 or the standard lymph node dissection for colon, but we are discussing about whether is there an advantage for D3 here. So what is the evidence available to us? Now, till recently, these were the papers which we were, in fact, till day before yesterday when I was preparing for my talk, these are the papers which was there. We knew we had some retrospective studies which were talking about the perceived advantages. There are absolutely no randomized controlled trials have till date. All the trials are all retrospective studies. They are not prospective. So what was told is that there is a non-stratified 15% survival advantage at 5 years. For stage 3, the difference in the survival is about 27%. But just last month, there has been a paper, which is a very interesting paper, and you need to see this data because this is not a small data. This is again a retrospective. In fact, most of the papers which have been used in this particular trial are all retrospective papers, and they are all observational papers. They are not prospective trials. But what is interesting is they have included nearly more than 20,000 patients in this. So 21,695 patients data has been analyzed in this, from which included more than, I think, around 2,000 papers. And this is a very interesting data, and I think this will be quoted in many of the recommend decisions which will come up in future, because randomized control trials are very far away from us. So look at this, the 5-year overall survival. The forest graph, if you see, there is a huge difference between the standard D2 and the D3. So the data is favoring the D3. Same way, if you look at the disease-free survival, same thing. Entire data is shifted, the forest graph is shifted towards the D3 dissection. And when you look at the local recurrence rates, this is D3 here. The local recurrence is significantly lower in the D3 group. So when we look at this data of this huge number of patients, we know that there is a difference in the when we perform a D3 dissection, there is a significant difference. So what do we really practice? When do we really need to do a D3 dissection? Now, if you look at this, the D1, that is just a marginal resection, or the D1 group of or pericolic group of lymph nodes can be dissected alone without anything, only in carcinoma in situ. Whenever there is a T1 disease, a D2 is required, and beyond this, or even T1 disease, it is better to do D2, sorry, D3. And because, most of the times we are not able to make out prior to surgery. It is always the histology or the final histology, histopathology reporting, which tells us what stage it is. So it is always safer to do a D3 dissection for all cases, because there is good enough evidence today to tell us that there is a survival advantage. So of course, in advanced diseases, and whenever there are nodes positive on CT scans, we have to perform D3. There is definite advantage. So what is the surgical technique? In fact, I perform mainly laparoscopic surgery, but I will not say that nobody should do open surgery for colon. I prefer, I don't even prefer robotic, because it does not require robotic technology at all for right hemicolectomy. Uh, so so, the advantages of laparoscopy would be the high quality of high cold, yield of in the surgical specimen, especially the most of the trials which have happened, like the color or any of those trials, the Korean trial, most of them have shown a significantly, better survival for the patient. The specimen yield is better. So I don't want to go into those theories. It's a completely different talk altogether if I go into that. But definitely laparoscopy has an advantage. There are many different ways in which it can be done, and either you go from that side to this side or this side to that side. There are different ways to perform the same thing, but at the end of the day, what matters is the quality of the specimen which you provide to the pathologist, which will really determine how the patient will do. That we know today. So what I do is a caudal to cranial approach, which is more or less a modified approach by me. So the surgeon stands in between the legs. The cameraman is to the left of the surgeon most of the times, but sometimes has to move to the right. Nurse, scrub nurse, and the first surgeon, first assistant. The camera, or the monitor is placed at the head end, and this is how is our setup. This is the port positions. I use this as the camera port, and these two are the assistant ports, and my two operating ports are here. So this is how I perform. There is another way to perform from the right when you're doing medial to lateral approach. So various approaches exist. So this is the video. This is a short video to show you how it is done. So so caudal to cranial approach. So first I've shown you the camera. Sorry, I think I made a mistake. Sorry. Yeah. So this is the so now the camera is from the lowermost, the suprapubic port. You are seeing the ileocholic artery over here. Yeah, ileocholic artery over here. This is the pulsation of the ileocholic artery. So we lift the ileum up, and I give it to my assistant to hold it up. So you can see the ureter here. The reflection of the peritoneum over the over here below the cecum is divided, and I get first into the retrocolic space. So here is where I actually reflect the mesocolon in with towards my specimen. Here this patient had some scarring around the appendix, so it was the anatomy was not very good over there. But as we go on, you can see the entire mesocolic fascia. That this is the retroperitoneal fascia. As we go up, that becomes the gerotas, and as you go up, so you can see the difference between the two. You are not breaching this plane. You go in this plane. You push the you can see the gerotas fascia now. You can see that white colored fascia over there. You push it down, and that is the plane in which you have to be. As you see, the Toll's fascia is just a loose areolar tissue. You don't really have any specific fascia that you need to divide. You go in between the two layers of Toll's fascia here. You are in the mesocolic plane, you divide the mesocolic Toll's fascia in between. Technically, that's what you're doing. So as we go up, we face the liver over there because you have finished the retrocolic dissection there. So that is the liver which you see. So that completes the lateral dissection. Now we need to complete the medial. In fact, the greatest advantage of doing this is half of the most difficult part of the surgery is completed. This is the duodenum. You're seeing the pancreatic head. This is the difficult area of surgery where the superior mesenteric vein is encountered. This is the superior mesenteric vein. This is the colic vein, superior colic vein, which is coming and joining there. So once that dissection is complete, you have lifted up the entire specimen. You go to the division of the mesocolon here, or the division of the ileocolic vessels. So you score the just distal to the ileocolic artery pulsation. You score the mesentery and head towards the pedicle. So we need to target the origin of the artery. So that is the idea of doing central vascular ligation. So mesocolic you saw the superior mesenteric vein right now, where we have lifted up all the lymph nodes. This is the ileocolic, I'm exposing the superior mesenteric vein over here. So this is a gauze piece which has been placed posteriorly in over the duodenum, superior mesenteric vein. This is the ileocolic pedicle. So we are lifted about more than half centimeter of the tissue around the artery and the vein. See, this artery and vein does not follow the textbook anatomy always. As it goes down, so vein is anterior to the artery, so your dissection is actually around here. You are not looking at, so they twist around each other. So your dissection goes, as it goes superiorly, the artery moves medial. So that these are the, ileocolic artery and the vein. And what you see behind, this is the duodenum D2 and the pancreatic head. Now, this is a very important area for all colonic cancers because this is the main group of lymph nodes which land here. In fact, the variations are so much that you have to, every step you need to be careful. So in fact, in this patient there are multiple middle colic veins. So we had to ligate each and every one of those veins. This is the middle colic artery, right branch actually of the middle colic. Because the branching had happened here, and one more root has already has gone to the left. So once that is done, you move the tumor along with the entire colon down. So you have to dissect the supracolic region now. So see, most of the venous dissection has happened above already, from below already. So the struggle with the venous dissection is already over. So very few veins are left. So this is the colonic veins which you are seeing here. Only we need to identify the superior, right gastroepiploic vein and ligate that. So that ligation is very important here. This is the formation of that vein, the loop of Kinley again. That's a loop of Kinley. Many times, in some cases, maybe over 40% of the cases, you can find a single loop of Kinley which you can just ligate, and that should be your single vein. So those cases are considerably easier. But most of the patients, the variations are a norm than finding a single vein. So this area, see, we have gone above the vein, formation of the or joining of the middle colic vein. We are dissected and got the entire specimen down. So this is after the dissection. This is the artery over here. You can see the artery, and this is the joining of the middle colic vein. Once we finish this, the right reflection of the peritoneum is dissected at the end, because that forms or that holds the colon in place, so that that obbliness is prevented. And then we complete the dissection and use a small incision, maybe a 4 centimeter or 3 centimeter, 4 centimeter incision to get out the colon. Now, in a case of extended right hemicolectomies, we always check the vascularity with ICG and then do the anastomosis, because we don't want a leak. We want to reduce the leak rate. Thank you very much.
Thank you, sir, for your wonderful deliberation. It was truly amazing to hear from you. Now, our second speaker, I would like to request Dr. Mark Ong T. Singh, sir, to kindly begin his presentation.
Okay, thank you. I'll start sharing my
Thank you,
slides.
sir.
Just a minute. Do I have to come out of the slide? I don't know. Or you exited already for me? Just a minute. I need to exit, isn't it?
Yes, sir.
Oh no, his slide has come. I think the team has done it. Thank you.
Can you see my slides? You can. Eh?
Yes, sir, we can see.
Okay. All right. Okay. All right. Let's see. I just need to make sure that 1 minute speaker view and okay. Oops. Just need to check something. Hold on. Okay. I'll start sharing now. Okay, everything good? You can see, yeah?
Yes, sir.
Okay, good. So a big thank you to the society for the very kind invitation. It's a privilege to speak to all of you tonight. Hello to friends, colleagues, and new faces. So it's nice to meet up, especially during this difficult time. So I've been tasked with a challenging topic, and I know it's getting late in the day. You've had a busy day at work, so I'll try to keep it a bit more philosophical tonight for everyone. Before I left for private practice 3 years ago, I was at the Department of Colorectal Surgery at Singapore General Hospital, where we welcome many good friends from Bangladesh who are still in touch with me today. And it's that reason that I'm here today. So thank you very much for the invitation. I did a dual fellowship in France and Denmark in minimally invasive surgery. This is where what I call home and work now. It's the Mount Elizabeth Novena Hospital. It's the latest in the 4 Parkway hospitals in Singapore and houses the first robotic platform in private practice. So this is my office.
Dr. Wong, I think we don't have your display. I think your slides are not shared. Please check.
Oh, you're not shared. Oh, okay. Let me go back then. Can you see my slides now?
Yes, sir. Now it's all right, sir.
Okay. Okay. So I think you've heard all this already. So I basically spent most of my professional training in SGH, where I've had the privilege of meeting so many wonderful friends from Bangladesh. I also served as a prof at Duke NUS Medical School, and I did a dual fellowship in France and Denmark during my time there. 3 years ago, I left for private practice. And this is Mount Elizabeth Novena Hospital, situated in the center of Singapore. It's a 333-bed private hospital that houses the first Da Vinci system in the private sector. So if any of you are ever in town when the borders open up, please look me up and I'll be happy to show you around. So this is my little cozy corner in the office. And so I've been tasked with speaking about the left side of the colon, and I think this is an opportune time to introduce the topic of the robot. And I totally agree with Sandeep that I also do not use the robot for right-sided colonic surgery, because I think the true role of the robot really is in the pelvis. But I thought I'll keep it more general, since not everybody in the audience does robotic surgery. And I'll share with you a bit about the MIS journey that I took, and looking back, what I think everyone should think about when embarking on the MIS journey in their careers. So this is the Da Vinci platform. It's about to start a case, so there's a lot of free time in between. You just take photos. So I think this is something that's still on everybody's mind. And before the seminar started, Sandeep and I were sharing about the backlog of cancer patients that now will haunt us in the months to come. And even though Singapore has already started to open up internally, our GPs are already starting to pick up on their cancer screenings. We are already seeing a little surge in cases of colorectal cancers who have been basically cooking at home during the pandemic. So it can only be so much more daunting in bigger countries, I'm sure. And the data is scary. I mean, this is out of the BBC in the early months of COVID, predicting more deaths from cancer than COVID should the lockdown continue for the foreseeable future. And out of the US as well, in the 2 months alone of March and April, there was a 30% drop in diagnosis due to an almost 100% drop in the scopes because of the pandemic. And as you can see, US is topping the charts in COVID-19 cases. So one can only imagine what the colorectal surgeons there are facing. So, okay, the MIS journey. I think we can all agree that laparoscopic surgery is really the standard of care and should be the standard of care. It is now in Singapore because the data through the COLOR trial and so many randomized controlled trials, good quality ones, have shown that there are definitely better short-term outcomes and similar long-term disease-free and overall survivals. So this is a picture of myself and my resident, not just wanting to look cool, but this is the 3D Olympus setup. That's why you see the monitor being very fuzzy in the background. So this is actually a pretty good alternative to a robotic platform, and definitely cheaper to install. Oh boy, someone's not very happy. Okay, thank you. Someone adding the blood effects maybe. So this is actually the 3D platform. So the images really pounce out on you, and it's a pretty good substitute to the robot for right-sided or colonic surgeries. So my personal journey with the robot started as a resident in the mid before 2010. So I did just about 20 proctored cases in Singapore before I left for my fellowship in France, where I did another about 30 cases with a prof in this picture. We were in Brittany in the north of France, where I did both cancers as well as pelvic floor robotic surgery. And upon coming back, we've done about another 50 cases since. So it's just an endless process of learning and fine-tuning. So when should we start? And I personally feel that you should start as early as possible. And this is a picture of the earliest documented humanoid robot. And any guesses for who came up with this? And it's none other than Leonardo da Vinci. Hence the platform being named after him. So I think it should be multi-tiered. Medical students actually should be exposed to this technology as early as possible, because medical students are treatment armamentarium nowadays. So you should know about it early. And from this early exposure, you can actually start to select people who have the aptitude for these procedures, and to then train them and develop them into a high-level team in the future. So referral sources also for doctors who eventually do not do laparoscopic surgery, they will get to know about it, maybe go to a GP practice or their non-surgical practices and know that you do it. And also it's good to get the industry and hospital commitment early for these expensive programs. So what do you actually need? Well, if I wanted to do laparoscopy and robotic surgery, I'll search out a center of excellence or tertiary referral center in my country, because then they will have the caseload of patients to support the use of the laparoscopy and robotic platforms, because the hospitals need the number of patients to get the return on their investments. The surgeons also, I think it's important that departments mandate that they all do laparoscopic surgery at least, and then to select individuals to then fine-tune their skills into laparoscopic, robotic, transanal, hand assist work, so that you have the full spectrum of services in the department or the hospital in the future. You also need industry help. So, get involved early with industry, get them to, provide you with didactic courses, wet lab sessions, simulator trainings, go attend conferences, seminars, get to know the leaders in the field. So it's actually a lifelong learning process for everyone. And you have to keep an open mind with newer technologies because they keep coming out. So what's the role of the robot in MIS? This is the SI in the Mount E Novena OT. Is it the holy grail? Well, I don't think so, because I think there's always need to improve. But certainly, we definitely won't be like this guy who's definitely redundant now. I think as surgeons, the good thing is our specialty is more of an art than a science. And I don't think, at least in our lifetime, the robots will actually replace us. At least doing complex rectal work, they won't. So why is robotic surgery coming up? And because of limitations in laparoscopy, I think it's quite clear. It's stable, there's no fatigue, the machine never fatigues, provided there's no power blowout. There's 3D vision, better magnification for sure, the dexterity beats any laparoscopy instrument, especially within very tight spaces. And as you'll see in the video later, it makes suturing very much easier. So as I was mentioning, I agree with Sandeep that the true place where the robot excels really is in the pelvis. And I strongly believe that benign procedures like rectal prolapse surgery is a fantastic place to start getting used to the robotic platform before you start to deal with cancers. And then I'll talk a bit about lateral node dissection, but not in the depth and detail as Sandeep did for mesocolic excision. So a quick dive into rectal prolapse syndromes. I think you've all seen this in your practice. This is a rectal seal and internal rectal prolapse on the defecating proctogram. And this is an obvious procedentia. And this all forms part of the spectrum of rectal prolapse in different degrees of severity. And so in my time in SGH, where we worked in the pelvic floor surveys, we developed an algorithm to select patients who would benefit from rectal prolapse surgery. And these are essentially the patients who presented with obstructed defecation syndrome. And with the use of MRI and defecating proctograms, we then selected patients who truly needed surgery. So the technique that I learned in France and brought back to start performing surgery for these patients would be the ventral mesh rectopexy. And so basically, this is really, I think, a good case to start robotic surgery if there's an opportunity, because it involves dissection, suturing, and then really putting the robot to the test in the pelvis. Basically, we insert a mesh between the rectum and the vagina in a woman, anchoring it to the promontory, the bone at the top, and then the pelvic floor at the bottom. So you get a full dissection all the way down to the pelvic floor. And once you get comfortable with all this, and then you subsequently embark on your TME for rectal cancer, it's quite a good transition. So we did quite a lot of papers in France with Prof. Lehieu, and we showed that this procedure, when carefully selected in just about 10% of patients with chronic constipation, actually showed significant improvements in their constipation and quality of life. So this is a quick video of what a robotic ventral rectopexy is like. So this is the uterus being hitched up. You can see a huge cul-de-sac here. And this is where basically the redundant sigmoid all falls in and basically compresses on the rectum during defecation. And it's very well illustrated on defecating proctogram. So these are very classical signs when you go into surgery for such patients. So when we do this surgery, we make an incision down along the right side from the sacral promontory down, and then we make a J incision across. And this is actually a retractor that you can put in a lady's vagina and retract forward to identify the plane more easily. So basically, you make an incision, you don't go all the way down, unlike a TME. So I'll just fast forward it a bit. And then basically, we then go down to the pelvic floor on either side of the rectum. The rectum is in the middle here. We see the pelvic floor here, the muscles. Actually, sometimes your assistant can do a PR and you can see the finger here. And then we basically create these two spaces on either side of the rectum all the way down to the pelvic floor. And then we insert a mesh basically down to the pelvic floor. We basically anchor it on both sides of the rectum. So this is absorbable permacore mesh because there's talk of mesh erosion for non-absorbable meshes. So, and then once it's in place, we basically suture the mesh down to the pelvic floor on either side of the rectum. So I'll just speed this up a little. So there's no resection or rectum, nothing at all. So it gets you used to the robotic platform, gets you used to dissecting close to rectum all the way down to pelvic floor. And so you repeat this on both sides. And at the top, you secure to the periosteum of the sacrum promontory, the top of the mesh. And then you basically suture it down to the bone. And then when this is done, you basically, the last step is basically hitching it up to the vaginal apex to obliterate that gap. And then we basically stitch back the incision that we made, reperitonealize and conceal the mesh. So at the end of the day, you basically don't see the mesh. So this is actually a very nice exercise with the robot prior to going into the complex rectal surgery. Oh, okay. So, okay. So for rectal cancers, I believe this is the other indication for the robotic platform. And there are two ways you can do it, either full robotic, that means you start the abdominal dissection with the robot all the way down to the pelvis, or you can do a hybrid. You can start laparoscopically mobilizing the splenic flexure and then only do the pelvic component robotically. There's no right, there's no wrong. And the data from the American Script database has proven that it's not only led to lower conversion rates, it's also translated to shorter hospital stays. So now my robotic patients go back at least about 2 days before the laparoscopic patients. So it's about three days or so. Definitely improved urinary function as well, and improved sexual function because of the better visualization and preservation of the pelvic nerves. And of course, we all want to get smaller wounds for our patients. Depending on the location of tumor, sometimes and the size, I either do a financial. Now I'm gravitating more towards financial because of the increased reports of incisional hernias from umbilical extraction sites. Yeah. So up to last year, the robotic cases have increased gradually over the last 14 years. So now this year, well, if not for COVID, we're probably hitting over 200 now. But I'm sure there are much more cases in India where Sandeep comes from. So this is a quick look at what happens inside when we manipulate the robotic instruments in real time. So this is an example of some of the port placements for a rectal tumor. So basically the principles about triangulation. That's the target there in red. The robotic ports are in blue. C is the camera. So that's the real patient, and dock it from the bottom on the left. So when it's all docked, this is the patient. This is the dual SI platform in SGH. Now the XI is available. So just a quick look at the anterior resection on a robotic platform. So this is the IMA ligation. So you can see the nerves coming up very nicely. And this is high definition in 2D. So when you operate, you actually see it in 3D, which is even more incredible. So that's the ureter there. Then here we are dividing the artery. I apologize, this one, we didn't quite skeletonize it enough. Then we go for the IMV. Okay. And then turning into the pelvis for the TME. So this is the rectum here. We're going to the pelvis. I find using a gauze is less traumatic than the forceps directly on the mesorectum. So it looks pretty wide, but I'm sure we all know that it's a pretty narrow space down in the pelvis. So this is on the left, you see the ureter appearing again, the iliacs, the gonadals. And so the assistant really is just helping with one retraction at most. He's evacuating the smoke, maybe cutting sutures. The rest of it really is all under your own control. So this is going down to the pelvic floor on the left. This is going down to the pelvic floor on the right. And here we actually can enter into the intersphincteric plane there, but there was no need to in this case. And so here's the stapling. I think this is quite standard otherwise. Okay, so the rest is quite standard. So I won't say too much about the lateral node because personally I don't practice it simply because I don't think the data is robust enough for it to be done systematically or rather routinely like what the Japanese do. And as with many procedures, it's very difficult to replicate Japanese and even some Korean data. So the West believe it's a distant disease, that once it goes to the group of lateral nodes on the wall, whether it's the internal, external, common iliac or obturator nodes, is considered distant metastases. And so the data seems to suggest that you can get distant mets up to a rate of as high as 20% over a 2-year follow-up. So is it worth doing this procedure, while incurring possibly significant morbidity of sexual and urinary dysfunction, and not to mention increased blood loss? So, but using the robotic platform is definitely the way to go if you are going to embark on this, because of the greater precision and visualization. So, okay, here comes a bit of philosophy. This is some of the tips and tricks. I hope I'm doing justice to your national team by showing this photo, because I'm not a cricket fan. But I think, as in any group activity, if you want to excel, I think building the team up is key. You need to have the right like-minded people who want to excel in this platform. You need to train together, whether it's a surgeon, your assistant, the anesthetist, and even the nursing team and the OT attendants who help set up the OT for your patient. We had a dedicated team in the Singapore General Hospital, and it just makes the running of the whole operations that much smoother. I chanced across this guy also when I was doing my research. I think he's a bit of an anomaly, but it's about choosing the right patient. Yeah. So if you're gonna start, I mean, don't be too ambitious. Start with someone who's not obese, super obese, young fella with few comorbidities, and hopefully not someone with a hostile abdomen. The pathology, I think, as I mentioned, rectal prolapse is a good condition to consider starting your robotic or even laparoscopic practice, or even a malignant polyp that needs to come out, or a small and early cancer. And just remember, if the lesion is small, you suspect this could be an early cancer, always tattoo it. And if you have to polypectomize it, you don't have a tattoo, a hemoclip is a good alternative. You can just simply take an X-ray and you roughly know where the thing is. The equipment, well, multiple monitors for sure, front and back for both yourself and the assistant. Smoke evacuators are useful, especially when you're operating deep in the pelvis. You don't want it to fog up all the time. As I mentioned, if a robot is out of the question, consider 3D camera systems like the one from Olympus. It's really good. ICG perfusion, as Sandeep mentioned, we use it for our colorectal anastomosis as well. I'll just show you a quick video later. Port placements. Okay, you know that there are many variations of port placements, and I think you have to be flexible to suit the body habitus. And don't fear putting more ports, especially when you're starting out. There's nothing to be ashamed about. But of course, don't end up, putting too many in, like until your patient looks like a Christmas tree. Then it gets a bit ridiculous. So this is an example using ICG. When I first started, we used it right at the end after the anastomosis. Now we do it both at the start, before we transect, and then after again. So this is laparoscopy, same thing. I won't bore you with this, but just to show you, after we transect the rectum and we do the colorectal anastomosis, okay, now it's coming out. And then shortly we'll ask the anesthetist to infuse the ICG. And you see the ICG lighting up both proximally and distally. This is just a fat over here. So nowadays we do it before we transect and then after as well. The same thing, pump air, no bubbling. Okay. All right. So the preparation for the surgery is also critical, especially when you have a huge uterus like this, for example, blocking your view when you want to dissect the rectum. It's always good to hitch it up. Now, there are various ways to hitch it up. We used to do it right through the body of the uterus, but that ends up pretty bloody. Now I prefer to do it on the sides of the body of the uterus, just under the fallopian tubes. But be careful of the ovarian vessels when you do that. A gauze is good to keep small bowel away, and I'd rather use large normal Reatec gauzes, wet them, unroll it to the full length, and put it in through your 12mm ports, and basically line them up along the entire small bowel mesentery route, and use that to keep the small bowel away. Because I find the small tonsil swabs, laparoscopic swabs, can get lost in your loops of bowel after a while if you're not careful. And if you're doing rectal dissection deep in the pelvis, it's always good to use a nylon tape to tie around the rectum and use it for retraction. Trust me, your assistant will really be very thankful, and saves him a lot of being screamed and shouted at. So personally, I think you also have to learn to operate in parallax in opposite directions. It starts with assisting a surgeon. So you have to assist in a lot of cases before you can start doing it yourself, so that you can teach in turn your assistant what to do to help you along. Practice laparoscopic stitching. I know this is the bane of a lot of us laparoscopic surgeons, but it can save you a conversion. It certainly can help with hemostasis. You can repair tears, even small enterotomies, colotomies, and of course intracorporeal anastomosis, for example, like in your colectomies. So this is one of my earlier cases where we did intracorporeal anastomosis. Probably Sandeep is better at this. So this is towards the end. This is the ilial limb, and that's the transverse colon over there. So I do bowel prep them if I'm going to do an intracorporeal anastomosis, just so that it's less messy. Yeah. If time permits, then this is actually quite good to start your laparoscopic stitching adventures. Okay. So, in summary, I want to leave you with this, and that's laparoscopy is the gold standard, I think, for colorectal cancer surgery these days. We should offer it up front, unless there are extenuating circumstances which tell us we should not be doing it. Robotics definitely for rectal cancer, and start your MIS journey early, and work and train in a team, and never stop your learning journey. So with that, I'd like to thank you all for your kind attention. Thank you very much.
Thank you, Markong sir, for your enlightening presentation. It was
Thank
indeed
you.
a pleasure to watch. Thank you, sir. Thank you very much.
Thank you.
Respectable audience, if you have any question, please post your question into the chat box.
Thank you, Dr. Sandeep, as well as Dr. Mark sir, for such fabulous and catchy presentation. Now let us move on to the next part, the panel of discussion. Firstly, I would like to invite Dr. Anil Hirur sir. Sir, please kindly share your valuable opinion and experience regarding today's topics.
Thank you. Thank you, Professor Alam. I enjoyed both the presentations very much. Sandeep was, it was a lovely video and a fantastic digging of such a hot off the oven article of right hemicolectomy. It is fascinating. It was fascinating to hear about the data, and I would really like to go through the article. D3 lymphadenectomy is something that I think in the subcontinent, especially, I think so we must apply our minds to it. A lot of our tumors are bulky. They do have a lot of nodes, and definitely, as Sandeep rightly mentioned, recurrences are mostly at the root of the ileocolic or the head of the pancreas, and they are very painful recurrences, and they are almost impossible to deal with once they happen. So I think that's my main take-home point. I enjoyed the technique that Sandeep showed, slightly different from what we do here. We stand on the left side of the patient. Our port positions are also different. But then I guess there are 9 ways to skin a cat. So each one has his own way of doing things. The ultimate result is what matters. I enjoyed Professor Dr. Mark Wong's talk as well. Nice to know about his journey about robotic surgery and the application of robotic surgery in so many different ways. Thank you. Thank you.
Thank you, sir, for your informative observations. Next, I would like to invite our Professor Shahadat Hossain, sir. Please, sir, express your comments about today's discussion. Professor Shahadat Hossain, sir. Sir, unmute Koran, sir. Please unmute, sir.
It was wonderful, Akishan, to receive Dr. Sandeep Nayak and Dr. Mark Wan. Both the papers were excellent, and particularly Dr. Sandeep Nayak drew attention to D3 dissection. I think our surgeons will be interested particularly to the adequate dissection, learning from him, and the wonderful result regarding the recurrence-free and longevity of the cases, longevity of the person they get. This is a very, very great advantage. I think it is not very difficult, but particularly for the junior surgeons, they will have to take meticulous approach, and it is possible. What you have seen, it is possible. I hope in our country, all of the new surgeons will learn it and practice it. That will be of benefit for the person, for the patient, for the nation. Regarding the presentations of Dr. Mark Wong, that is also very, for us, this is also very much enthusiastic for the persons or the new surgeons. What he has particularly drew the attention to learn the new things, to learn the new technology. It is the juniors. They have got the time to learn it, and they have got the energy and actually interest to learn it. So all of you, I would encourage our junior surgeons particularly to take interest in this field. And my approach to Dr. Mark Wong, if he has got any facilities to arrange training for our new surgeons in his place or in his country, will be very much appreciated. So thank you very much, both the doctors, Mark Wong and Dr. Sandeep Nayak. Thank you.
Thank you.
Thank you, Professor Shahadat Hossain, sir, for your nice comments.
Thank you.
Now, please let me invite Professor Shahadat Hossain Sheikh, sir, to share his views and ideas. Professor Shahadat Hossain Sheikh, sir.
Thank you. Thank you, Arif. The amazing presentation of both the speakers. Sandeep Nayak, I have seen his work previously.
And the Mark's presentation, many tips we got from his presentation. So basically, I have no question. I can just like to share some opinion. So is my voice is okay or echo is going on?
No echo, sir. It's okay.
Okay. So, Sandeep, I like to share some opinion from you. Like in every cases, if you think on CT scan, there is T2 lesion and the lymph node up to D2, do you like to advise for the D3 dissection, or you like to be confined to the standard D2 dissection?
No, presently as a standard of care, we do D3 for all the patients because we hardly ever find a T1 disease. So T1 is the only case where we really can do, means, you should have a proof that it is only T1, and that is very difficult to get pre-operatively.
Yes.
So I don't want to take a risk. And many of our patients come with bulky disease. So I don't see any point in really taking a risk of doing less. So I would always do D3. That is my standard of dissection. D2 will be an exception. Anything less will be an exception.
Okay. Okay. About your port position, if you plan extended right hemicolectomy, do you change your port, or as your standard port you go for the extended right hemicolectomy?
No, my ports are same, exactly same, because with same ports I can manage all the I can reach everywhere in the abdomen, so I don't need to change anything.
So you deal this splenic flexure from the same port from the. So you said you stand on the both in between the leg to leg.
Exactly. I may move myself so that I can complete the dissection. I rotate, tilt the patient accordingly, so I'll be able to, because I'll get once you get all the ports in straight line. If you go to the left, you can mobilize the splenic flexure also. Sometimes it could be tricky to do it, but it is possible to do most of the cases.
Okay, another issue I'd like to share with you and Dr. O'Neill Hirod and as well as Mark. So something is like, if the T3 tumor in the hepatic flexure or the transverse colon, some literature shows the 15% lymph node is along with the gastroepiploic vessels. So what is your opinion about, should we take the gastroepiploic vessels along with the extended hemicolectomy, or we just keep the gastroepiploic vessels?
Gastroepiploic, right? Gastroepiploic is not required unless there are lymph nodes which are detected on scan. It is not a part of the standard. These are all extended lymph node dissections. If you go with the extended, what is said is at the insertion of the right gastroepiploic, that is loop of Kinley, the vein. So that vein has to come in the specimen. Like I showed, the vein comes along with the specimen. You ligate the vein. The root where the vein inserts into the superior mesenteric vein or loop of Kinley has to come into the specimen. So that is the area which has to come, not the right gastroepiploic artery. So the root of the artery are not going, unlike we do in the gastrectomy. So that's where we go into the root. Here we don't need to go there. We'll restrict ourselves to the vein. So that constitutes the D3. I hope I have answered that.
What is your, yes, anastomotic technique?
So is it to me?
Yeah.
What is it, sir? I didn't get you. Sorry, can you repeat it?
Anastomotic technique into right hemicolectomy.
Is it, what is my anastomotic technique?
Is ileocolic? Yeah.
Yeah, I do ileocolic, side to side most of the times, or end to side to end. I usually, because the anastomosis can be done once you extract the specimen extraction wound. So I usually prefer to do it through that wound only, because I put the incision, midline incision high up. Even if it is when we do a lower down a phalansteal incision, we may do it intracorporeally and extract the specimen from below, but I don't see a great advantage in doing it, so I don't do it unless the patient asks for it. I don't do it.
Okay. Okay, thank you, Sandeep. So
thank you.
Some opinion from the Mark. So Mark, thank you very much for your many tips in your presentation in the minimal invasive surgery. So in every cases for the left colonic surgery, do you ever go for the CT angiogram to see the whether there is vascular anomalies or not? What is your routine practice?
No, I don't routinely map out the vascular anatomy for the left colonic resections. I think the anatomy is definitely there's variation, but with regard to ligation of the IMA root, I think that's pretty consistent. And I think the only areas where the vessels may vary is probably in the watershed areas when you're dealing with the splenic flexures. But in the Asian population, at least in Singapore, unless you're going all the way down to the pelvic floor, we don't routinely take down the splenic flexures at this, even for today. So so having said that, no need for a routine CT angio, but just a stage CT scan for staging purposes, and that's about it lah. Yeah.
So you use in every case as ICG before anastomosis?
Yes. So ICG now, again, it used to be whether it was available or not, but now, at least in private practice, it's a bit more consistent. I find the system that's most suitable is really the one by a striker, because the image that you saw earlier, they actually managed to superimpose the real-time image with the fluorescence image. I think Sandeep will agree with me also that there are many systems out there, but some of them just shows a blackout and some green patches here and there. So the technologies that allow an overlap, superimposition of the real-time image with the fluorescence, that's really the one that you should be considering in your laparoscopic setup. Yeah.
Okay. And another small issue that's really debatable in every time. What is your practice in case of the tumor in the splenic flexure? Do you prefer the segmental resection or extended colectomy or formal left hemicolectomy?
So I think personally, my preference is for extended right hemicolectomy. I think it's probably more optimal, and but I weigh it against some other conditions like the age of a patient, for example. If it's a very elderly patient that we're talking about with a splenic flexure tumor, taking out 3/4 of the colon can this patient with probably a life of a lot of diarrhea, which can be quite crippling. The other reason why I do extended right is because I think the anastomosis probably is better. There's less chance of a leakage than a colocolic anastomosis. Idiocolic is always favored. And sometimes if it's obstructed in the splenic flexure, then you don't get a chance to evaluate the proximal colon. Then extended right is probably favored. But it is a bigger operation, taking out so much colon. So my first choice is always an extended right. And then for selected cases, probably a segmental or left hemi.
Okay. So you personalize the cases.
Yes, yes.
So thank you. Thank you once again, Mark, for your wonderful presentation and joining this webinar. Thank you very much. And thank you all.
Thank you. Thank you so much.
Thank you, sir, for your valuable discussion. Now I'd like to invite Honorable Professor Abu Tahir, sir. Please, sir, say a few words about today's discussion. Professor Abu Tahir, sir.
Thank you. First of all, I gratitude to and respect to chairperson, our learned teacher, Professor Mutur Rahman sir, the chairperson of this webinar, and honorable chief guest and our guardian and renowned neurosurgeon, Professor Dr. Konokanti Borua sir, Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, and two renowned speakers, Dr. Sandeep Nayak and Dr. Mark Ong, teaching. For their, I salute them for their nice and beautiful presentation. And respect to panel experts, and thanks to all the moderators for their nice moderation. I enjoyed Dr. Nayak's presentation. Actually, for the last 30 years, colorectal surgery developing, but in rectal surgery, there is many, whole world accepted that the total majorrectal excision is the optimal management for rectal cancers. But colon surgery, still it is debate, what is the optimum surgery. Today, Dr. Nayak shows nicely D3 dissection and D2 dissection, and what is the improvement and difference in D3 dissection and D2 dissection. In case of complete mesothelial excision, that means it also included D3 dissection. there is dramatic improvement in disease-free survival, which is improved from 50% to 75%, and local recurrence dropped from 30% to 5 to 8%. And also, this time metastasis and other complications also less in complete mesocholic excision. And he nicely showed by his presentation. Thanks for his nice presentation. And Dr. Mark Ong also nicely showed ventral mastectomy for rectal prolapse, and also for rectal cancer anti-resection and left hemicolectomy. Actually, in robotic surgery and laparoscopic surgery, there is still gold standard is a laparoscopic surgery, but in robotic surgery there is greater precision and better visualization of the fields. For this reason, we can easily now spare EG. So I think from these two presentations, I learned a lot, and our participants who participate today, they also learned a lot. With these few words, I'm concluding my speech. Thanks to all.
Thank you, sir. Thank you for your valuable opinion. Thanks all the panel of experts of today for participating in this session. Thank you, sir.
We have reached the penultimate session of today's webinar, that is the interactive question and answer session. We have had a handful of questions, some in the chat box, some sent in the other media. Okay, I'll start with first question from Dr. Sajjad Haider. It's to Sandeep Naik, sir. Is D3 dissection mandatory for any site of right-sided colon cancer? Is there any difference for like carcinoma cecum and carcinoma hepatic pressure? Is there any difference?
See, the lymph node dissection is standard. D3 dissection is standard. It will become standard because of the data that is emerging, though it is a retrospective data which to really look at seriously. And it is going to become standard. And as a practice, I have been doing it for a long time now. So for all cases, we do D3. We don't compromise on the lymph nodes.
Understood, sir. Thank you. Then the second question is from Joby Ponte to actually there were two questions. One is answered in the chat box. The second question to Dr. Sandeep. First question was to Dr. Mark. To Dr. Sandeep, sir, again, do you routinely ligate the gastrocolic trunk of the SMV?
Yes, the gastrocolic trunk has to be ligated, from the SMV. See that, again, the understanding of anatomy of gastrocolic trunk has to be clear. We need to understand how it looks. It varies from patient to patient. There is a lot of variation. So, you have to ligate in such a way that a sufficient number of lymph nodes are taken, because the formation of the gastrocolic trunk is the good, important thing to understand in each and every case. And there is no way to make it out prior to your surgery also. There's no studies which will tell you that. So it is on table. You have to understand the anatomy and remove the lymph nodes which are up to ½ centimeter above the joining of the that trunk with the artery. Vein, sorry. Practically, that is a landmark, if you see.
Thank you, sir. There were two questions to Dr. Mark. One was already asked by Professor Shadab Sheikh, sir, about the splenic flexure tumors. The second question is, what is your take, Dr. Mark, on the segmental colectomy for carcinoma transverse colon or sigmoid colon? Your take on segmental colectomy for carcinoma transverse colon, or sigmoid colon. Do you prefer, in selected cases, to use segmental colectomy on these locations?
Oh, okay. Transverse colon, definitely a right hemicolectomy, because I think it's definitely more oncological, and also because
you mean an extended right hemicolectomy, sir?
Yes. anywhere along the transverse. I wouldn't do a transverse colectomy. That's right. And also because of the anastomosis. I think I trust the integrity of either colic anastomosis much more than a colocolic if I can avoid it. For a sigmoid, I think it's an anterior resection for me. So I don't do a sigmoid colectomy these days because when you do a sigmoid colectomy, you don't actually go down to the IMA root. So when you do that, I've seen many folks end up with, or they take the IMA root and just take a short segment of colon, and then they end up with an anastomotic leak. So if you do a proper sigmoid colectomy, it's not oncological, but if you try to just take out a segment and do an IMA ligation, then you're in for trouble. So I'd rather do a anterior resection. Yeah, taking it out of the. That's right.
Very nicely explained, sir. Thank you so much. Sir, Dr. Anil Halur, sir, this question is to you. Do you practice neoadjuvant chemotherapy for colonic carcinoma? And if yes, in which cases?
No, as of now, neoadjuvant chemotherapy is not supported by evidence as far as colonic cancer is concerned. The evidence is strong in rectal cancer, but in colonic cancer, it is not. I wouldn't do neoadjuvant chemotherapy as a matter of routine for any colonic cancer.
Okay, sir. Thank you. And another question to you too. What are the indications for adjuvant? It's another debatable question. What are the indications of adjuvant radiotherapy in carcinoma colon?
Adjuvant radiotherapy in carcinoma colon, there are very few indications, especially we would consider it if the abdominal wall is involved. Other than that, or if there is a very painful recurrence, in those situations, probably palliative radiotherapy would help. But as a matter of routine, I wouldn't think that the adjuvant radiotherapy is required. It would be required only in palliative situations or in tumor would involve the wall. Abdominal wall, but otherwise I wouldn't think about radiotherapy in carcinoma colon. Again, we are distinguishing here between the colon and the rectum.
Between the colon, yes, sir. Any other panel of experts would like to add to anything regarding neoadjuvant chemotherapy?
One thing I wanted to just ask Sandeep and Sandeep's views on, and everybody's views here regarding the D3 dissection. So I agree that the evidence is, I agree this is a retrospective thing. Don't you think that we should wait for a D2 versus, there are two issues here. One, though we say that the D3 dissection is obviously going to give good results, and we accept that. My only concern is that in Sandeep's hands, he's an expert surgeon. It looks very easy and nice. But handling the superior mesenteric, especially when you go on to the left side of the superior mesenteric vein, then you are really dealing with, you really have to have a very good technical hand to do it. A young surgeon probably doing that may end up in a lot of problems because it's not the inferior mesenteric, it is a superior mesenteric. So you're going to lose more than all the small bowel along with it. So if the vein opens up, should we really wait for evidence which compares D2 versus D3, because we have nothing to say that the difference between D2 and D3 is very marginal. So should we wait for evidence which compares D2 versus D3 and study the patterns of local failure when a proper D2 is done? So if you see the patterns of local recurrence when a D2 dissection is done, the incidence is roughly around 11%. But if you have a local resection is done, then the incidence of local recurrence increases. So should we wait for that evidence? What do you think, Sandeep? And anybody in the audience?
See, my take is that, yes, a good D2 should be done in all cases. There's no doubt about that. But doing a D3 is matter of training. You have to be comfortable with what you're doing, because when you're dealing with especially SMV, it is tricky. There you have a bleeding. If you don't know how to handle SMV, you are in trouble. That's a very difficult area. The loop of Kinley formation, the way it really works, and it is not easy area to handle. So yes, at least. But if you see lymph nodes in D2 region, of course you have to go to D3. So it is better to send it to people who can do D3. But in a standard case where you're not seeing any large lymph nodes in the mesentery in the CT scan, uh, as of now D2 should be good enough to give a fair results for the patient. But as we I don't know when the trials will happen, when we will get, because surgical trials, as you know, are extremely difficult to really fashion and give a credible result. In fact, surgery will always remain an observational and retrospective, and good trials are extremely difficult. Everything becomes controversial, like our other lip trial, our cervical cancer trial, and everywhere it will become a problem. You'll never get a good result, highly credible result. Very few trials have given. So my opinion is, try to do D3, but if you are, or learn D3 and do it. If you are not able to, at least do D2. So at least you are avoiding giving some good results for the patients.
So I think a good surgical audit of one's own results when you're doing a D2 dissection is very important, I think, because a pattern of recurrence, local failure that happens after your surgery, I think that tells us quite a lot about what is the kind of dissection that works in your kind of patients. I think that is very important.
Yes, and also what you have to look at is, see this result which I have shown. I think, though retrospective, we have to give a lot of value to this particular paper. Though I'm yet to go through in every, because I told you, I found this paper in the morning when I was doing a literature search. I just wanted to check if there is anything new, and this is what I found. So I'm yet to go through every word of it, but whatever I went through, I found it very interesting. It is very interesting.
Thank you, sir.
Another thing for Mark. Do you think that robotic would be a good instrument for doing a D3 dissection? I know Sandeep mentioned that robotic, it doesn't make a difference, but since you are heavily into robotic surgery, I was just wondering whether you really would you like to do it robotically? No other considerations, robotic versus laparoscopy D3 personally.
Unmute, sir. Unmute, sir.
Mark, you have to unmute, please.
Dr. Mark, you have to unmute.
Sorry about that. No wonder you're all smiling. I think for me the challenge is I've never started on this D3 adventure, but if I were to do so and I have a robot at my disposal, I think it will be very tempting to start the journey on a robotic platform, and I'm sure Sunny will agree. The views and the dexterity of the robotic instrument will certainly make it much more pleasurable. But really, it's a cost benefit thing. So you should not, I think, invest in the machine primarily just to do colonic and right-sided resections. But if it's there and the urologists are not using it on that day, and you have a beautiful case for D3, why not?
Yeah. I asked this because Sandeep, honestly, I felt the robot was much easier to do a D3.
Yeah.
Because the view and the depth that it gives, it's much
I'll
better.
tell you where the problem will come. See, I have done quite a fair number of robotic whipples also. So when we are dealing with that region, and when you have to operate above and below the mesocolon, transverse mesocolon, you have a lot of trouble moving the colon up and down. See, robo is very good when you have a specific target you operate. But when you have to move something very heavy up and down, it struggles. In fact, you can't move it. You will be so. In some patients, it is possible to complete the entire dissection. Whatever I showed, it's possible to do from below itself. You can complete the dissection. So in those cases, it is possible to do. But at the end, you will struggle with the last part.
So one of the solutions I found was to use 2 arms and 2 assistant ports. So then it makes it a little easier to handle
You've done it?
So I think Professor Sheikh, I think it's high time that Bangladesh gets a robo now.
Very good.
Yeah, hopefully.
So God willing, there will be a robo next time we come to Dhaka.
Yeah,
Super.
Dr.
Okay.
Dr. Nayak, actually, Dr. Nayak, you can hear me?
Yeah, I can hear you.
Yeah. In D3 dissection, that means complete mesocolonic excision, there is lateral dissection lymph node, 10 centimeter is enough. But European surgeons, they follow more than 10 centimeter. What do you follow? And what is the...
In colon, the standard of the extent of colonic resection was based on the vascular ligation. It was not based on the, we don't dissect based on the where, just based on the location of the tumor. It is which vessels you ligate will dictate how much you will resect. So what we talk about in D3 is, it is possible to reduce the length of resection by going more into the depth of lymph node dissection, because the recurrences don't occur beyond that particular segment of mesocolon. It will always occur within that 5 centimeter mesocolon up and down. What recurrences will, you should go to the root and resect the origin and the lymph nodes in the D3. That is the principle of D3. So, for example, you can do a good transverse colectomy and do the anastomosis if anatomy permits over there. So it's possible to do it, but if you go to the root and remove the D3 lymph nodes in that case.
Central lymph nodes.
So that is central lymph nodes. Yeah. So that is essential. That is the principle of doing it.
Thank you.
So if you actually look at, there is one nice paper which studies recurrences in the rectum, and they have defined local failures as axial failures and lateral failures and circumferential failures. So that is a very good study. And in that, you will see that the axial failures are very, very low. It is essentially what fails is normally when your CRMs in the rectum, especially when your circumferential resection margins are not clear. I think this obsession with mucosal margins is really not valid, because if you take a good circumferential margin, obviously your mucosal margins are going to come negative. Because to achieve, for example, in the rectum, if you achieve a good circumferential margin, you have to go beyond the tumor. Otherwise, you will never get a good CRM. Otherwise, your specimen will start coning. Yes. So if you achieve a good circumferential margin, your mucosal margins are good enough. And I think the same applies in the colon. In the colon, especially, if you do a good lymph node dissection, the vascularity will not permit you to have a positive mucosal margin, because it will be an obviously visibly dead colon that you will be holding. So your mucosal margins are of no concern usually.
Thank you, sir, for that enlightening discussion of yours. Sir, we are almost nearing the end. We have a couple of more questions. One is in the chat box. What is the histopathological specimen differences between the conventional right hemicolectomy and D3 right hemicolectomy? Anil sir answered nodal yield is obviously more. Would anyone like to add to anything to that? The histopathological specimen difference between conventional right hemicolectomy and D3 right hemicolectomy.
See, we should look at the mesocolon. The fat globule should not be exposed in the mesocolon when in a good mesocolectomy when we are doing. So
intact mesocolon should be there.
Yeah, right. Intact mesocolon, and the fat globules, mesocolic fat globule should not be exposed. So that right. Plane should be very, very. It should be a glisten, just like in rectum. The surface should be glistening. Right. So right. That is essential. So that plane, attaining that plane is very important in this, and so that is the main difference. I think that's why that whoever has asked is asking about that question. Is it like rectum? So it is similar right. to rectum. When you look at it, you can make out. But in this, it's a plane surface. There, it's a circular surface. That is the difference.
There's a final question.
Yes, in D2 dissection, it's clearly showed by the Dr. Nayak. But in D3 dissection, what we are doing, it is there we are doing the meso or mesocolon up to the anterior surface of the supramedullary artery or supramedullary vein. So there is more mesocolon and lymphoadipose tissue. So there is more picking up of the lymph nodes than D2 dissection in D3 dissection.
That's all is the difference. See, that's what I was talking
Absolutely,
about, the difference between the mesocolic excision, central vascular ligation, and the D3 lymph node dissection. The three are actually different concepts. We should not mix the three together. I mean, they are part of each other, but they are not the same. You
They are
cannot
complementary, but not similar.
exactly. Yeah,
Right,
they're.
sir. Thank you, sir. Sorry, second question again. Do you recommend routine use of prophylactic mesh during stomach closure? Anyone, sir? Dr. Mark? Can't hear you, sir.
No, I don't routinely use a mesh to stomach closure. I don't think there's
Why the
any
question? But why the question? Why?
Because yeah.
Is it common to have a incisional hernia in all patients undergoing a stomach closure?
No, actually not all patients. Not all patients, but as the stoma is there, so there are some
clinical or subclinical peristomal hernia is there. So in that perspective, to reduce the postoperative hernia, whether that will be beneficial or not, if you put the mesh when during the stomach closure.
See the
like the permanent
yeah.
stoma, when you do the permanent stoma, then prophylactic mesh there is an option, something like that.
One of our students did research on prophylactic mesh use in stomach closure, and he showed that there is dramatic there is less peristomal hernia which is used by the prophylactic mesh than which is not used.
What was the infection rate? Because I would be really concerned with mesh infection and mesh extrusion in those cases. I don't know. I would be really interested to see the study actually. What is the result with the mesh infection? Because it's a dirty wound as such. Stoma is a dirty wound.
Yes.
In fact, I would be really concerned about the mesh infection.
Sandeep, I think that not much, because the permanent stoma, there are a lot of study with the prophylactic mesh. So the infection rate is not that high we expected.
Sir,
but I will let you know the study result. I'll convey.
Mesh stoma closure, I would be really concerned.
Stoma closure, if you put a mesh, then I agree with Sandeep. Plus, will it be an onlay mesh or will it be an intraperitoneal? I mean, where would you put the mesh? Because the sheath is almost absent there. When you're doing a stoma closure, the sheath is, you have to really strain on the sheath.
Only. We are just the study is going on. We'll let you know the result about the infection and everything.
I guess that was an intriguing question. Okay, the last question. It's actually a real life scenario. Someone has sent a 60-year-old male, no comorbidities, obstructing left colon cancer, sigmoid cancer. Emergency Hartmann's procedure done. Histopathology T3N2M0, received adjuvant chemotherapy. Prior to Hartmann reversal, colonoscopic evaluation of the proximal bowel revealed a sessile 1.5 polyp in the hepatic flexure. Biopsy showed well-differentiated adenocarcinoma. So now what's the plan of management? Shall I repeat, sir? It's an open question to all the panelists.
No, there was a primary one cancer in the sigmoid colon, and then
yes, sir. It was obstructing. Emergency Hartmann procedures was done. It was revealed T3N2M0 pathologically, and then adjuvant chemo received. And now before Hartmann reversal, the colonoscopy evaluation of the proximal bowel showed another sessile polyp, which was well-differentiated adenocarcinoma, and it was 1.5 centimeter inside, located in the hepatic flexure.
And what was the base of the polyp? Was it positive or negative?
No, sir. The base of it was a sessile, so it was colonoscopic biopsy was done. Colonoscopic polypectomy was not done.
So basically, the polyp base is positive.
Sir, that is not mentioned because
base is not evaluated. Just biopsy is taken and adenocarcinoma well differentiated, right?
Yes, yes, sir. Yes, sir.
Abdominal colectomy would be what I would prefer to do in this case. Total abdominal colectomy with because he's 60 something, you told the patient, so rectum seems to be okay in the I believe rectal scope, sigmoidoscopy has been done anyway, so rectum is clean. So
yes,
we have an option of doing total abdominal colectomy with ileorectal anastomosis. That's what I would prefer to do. Only other option is total proctocolectomy, but there's no evidence to do that in this case. We don't have, we are not done any, but definitely germline mutation testing would be indicated for double malignancy.
Yeah. That was I was going to ask about.
Yeah.
Would you suggest?
Yeah, I absolutely agree with Sandeep. So is there any different opinion from the Anil or from Mark?
No, I would agree.
Yeah.
So you go, Mark.
No, I was just saying that I agree. A total colectomy.
Okay.
For him.
That's right.
Yeah, so I think a subtotal colectomy is online. Of course, we have there is no other option, because if there is a polyp which is obviously malignant, and we should test this patient for germline mutation, and it could be a lynch. So definitely we must rule that out, and then screen other family members as well, because then this becomes much bigger than just a single polyp or a single individual patient.
Yes, sir. Well, I guess that brings us to the conclusion of the question answer session. That was a very interesting and well participated session. Thank you all the panelists for joining so actively. Now we come to the concluding session. I would like to.
সিনিয়র প্রফেসরের কাছ থেকে কিছু কমেন্ট নিতে পারো যারা আছে যে
So before the formal concluding session, I would like to take some remarks or opinions from the senior professors who have joined us here. Professor Ibrahim Jamal, sir, Professor Sir. I could see Professor Jamal sir a while ago. Okay, sir. Professor Dr. Mutalib sir is here with us.
Thank you, Istiak. Thank you for arranging such kind of webinar. I'm very much delighted to observe this kind of webinar. To foreign delegates, speaker who present the two different cases, it's fine. Actually, the surgery for the colonic cancers are difficult, but nowadays, due to use of laparoscopy and the robot, make it easier. So our aim is to make this difficult task easier, and especially the young surgeons. Their learning curve will be easier if we do such kind of webinar frequently. Thank you. Thank you very much.
Thank you, sir. Professor Imtiaz Farooq sir is also with us. Would you like to say something, sir?
Assalamu alaikum. It's a very nice webinar. I enjoyed a lot, and the discussion part is nice. So we learned this webinar, and thank you the organizers and the speakers. Thank you.
Thank you,
so much, sir. Professor Dr. Mohammad Baharul Islam, sir. Sir, please unmute. I cannot see him. All right, then probably we then will have to come to the concluding session
আমাদের
finally.
ইশতিয়াক আমাদের সোসাইটির সেক্রেটারি আছে
আমি স্যার আসলে আমি পার্টিকুলার লিস্টে দেখতে পাচ্ছি না। ও ইয়েস, সরি, হ্যাঁ সরি, Dr. Nur Hossain Bhuiya Shaheen sir, he is the Secretary of the Society of Surgeons of Bangladesh. Shaheen sir, would you like to say something, please?
Can I hear you?
Yes, audible, but we cannot see you.
Because video is disabled by the host. That's why you cannot see me. I don't know why disabled. Even then, respected chairperson, Professor Motiur Rahman sir, Honorable Chief Guest, Professor Konakandi Borua, Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, both the learned speaker, Nayak and the Mark, and the panel of experts, Anil Hero, Professor Shahadat Hossain Sheikh, and Professor Abu Tahir, and all of the audience. It is actually time demanding presentation, and everybody in the world now facing the laparoscopic or robotic arena. It is now. So I think the discussion part is very, very interesting, and everybody actually everybody enjoyed and the learn from the discussion part. So that's why this is the another issue. I think that if the discussion part is more in every presentation, that is the better. So thank you very much. Thank you for giving me the opportunity to talk some with the learned audience. Thank you very much.
Thank you, Dr. Shaheen, and apologies that I couldn't find you on the list. Okay, now we are coming to the final part, the concluding session. I would like to extend my heartiest congratulations to the 100-odd attendees who have been present here, and special thanks to the speakers and the respected panel of expert members. And I would also like to thank our scientific partner ACI Pharmaceuticals Limited and our media partner Raj TV. Now for the special remarks of the chief guest, I would like to request Professor Konakandi Borua sir to have a few words. Sir.
Respected chairman of this webinar session, my teacher, Professor Motiur Rahman, learned speakers, Professor Sandip Nayak and Mark Owen, and panelist, Professor Anil Herer, Professor Shahadat Hossain, and Professor Shahadat Hossain Sheikh, and Professor Abu Tahir. Lastly, professors are my colleague in Bangabandhu Sheikh Mujib Medical University, and other faculties present in this webinar session, and participants, ladies and gentlemen, very, very good evening to you all. I am very much enriched by the presentation, learned presentations by two speakers, Professor Sandip Nayak and Mark Owen. They have presented in detail both in laparoscopic surgery as well as by robotic surgery, how much extent dissection of the colon as well as mesocolon and lymph node dissection regarding this. I think they have presented in details, and at the same time, the panelists, Professor Anil Herer, Professor Shahadat Hossain Sheikh, and Professor Abu Tahir, they have discussed the matter, and the technical tips are also being discussed by the panelists, as well as we have the answers from the learned speakers. And this is the way how to develop the technical expertise among our juniors. I think with this, they have, by this webinar session, we can extend our knowledge and enrich our knowledge. I also congratulate the organizers for organizing such a wonderful webinar session, And I am also extending my thanks and gratitude to them for inviting me to chair this function as a chief guest. Thank you very much.
Thank you, Professor Konakonti sir, for the kind words. Now, for the final concluding comments from the chairperson of this webinar, I would like to request Professor Moti Raman sir to take the mic, sir.
I'd like to thank Dr. Sandeep and Dr. Mark and also Dr. Anil, also our panel of experts, for the wonderful session which we have this evening. Dr. Sandeep has very nicely shown the controversial mesocolic excision with central ligation of the colonic vessel. I've enjoyed thoroughly your description, and really that has explained a lot of ambiguity from your description. Thank you very much. And I'd like to thank Dr. Wong for the laparoscopic and also the robotic exposition of the colonic surgery. And your demonstration of prolapse, then malignant, the colonic ulcers, that's wonderful. And as you have mentioned, that probably the rectal surgery will be better by the robotic and the rest by the laparoscopic. From your description, I feel that is absolutely correct. Well, I'm very much happy to have you in this webinar and hope to see you again in the near future. And thank you very much for demonstrating your expertise, not only to me, but also my young colleagues and my junior friends. Thank you very much. Thank you all.
Thank you. Thank you, Prof.
Thank you. Assalamu alaikum.
Thank you, sir. With that, we would like to conclude the session for today. Thank you again for the foreign delegates to have made time for us, and it's a pleasure hosting you here. And we hope to see you next time. Thank you so much.
Thank you.
Thanks for having me.
Thank you also.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.